And I promise I'll get to you, Dr. Chin, but really quickly, you said two things and really kind of quick answers to these ones. One, is there a role, this is for you, Julia, is there a role for radiation for brain metastases? And then the second, when you look at an NGS report for someone with a classical EGFR mutations, are there any additional mutations you're looking at to try to guide your decision making in terms of whether to stick with osimertinib by itself or whether to add something?
Yeah, I'll do those quickly. So first, brain metastases. So, certainly brain radiation is a useful tool for treating brain metastases, and it can be well tolerated. It's very focused and precise to just a few spots. But one advantage, as Dr. Chin also brought up, is that our modern targeted therapies often are very brain active, and that they get across the blood-brain barrier and they treat brain spots with a lot of confidence, almost as much confidence as we have for treating disease in the rest of the body. And in those situations, like when I'm starting on EGFR lung cancer or ALK for that matter, I'll usually put off radiation because it does still have risk of side effects and some risk of long-term side effects, and try to let the pills or pill-based combinations work on their own first. But then we want to watch those brain spots very closely so we're ready to treat them if they do grow. So that's the first answer. And then the second one, remind me, it was about...
Yeah, the folly of asking too many questions at once. Yeah, so I said that we've talked about biomarker testing and its importance, and we sometimes focus on the key biomarkers.
Co-mutations,
like EGFR. Yeah. Exactly. Are there co-mutations that impact what you do?
For me, I'm actually not looking at co-mutations, but I will say that there are some like TP53 co-mutations or TP53 and RB co-mutations that have been associated with shorter on average duration of benefit to targeted therapy pills like osimertinib alone, and maybe associated with increased risk of certain forms of acquired resistance, like transformation, something called small cell lung cancer, which is a more aggressive, a little harder to treat form of lung cancer, though lots of progress, as you heard in an earlier talk. So people on those with those features do have a little shorter average duration of benefit, and they do gain benefit from adding combination upfront therapies. To my eye, I think the degree of benefit is similar in terms of magnitude of gain whether you do or don't have those mutations. I'm personally not intensifying based on that particular factor, but there are folks who do like to intensify based on it. So I certainly see that happening in practice, and I think it's within the realm of sort of a reasonable way to interpret the data. And certainly if I had someone who was on the fence and they had other features that made them kind of high risk and they had that co-occurring mutation, just one more thing that's going to tip those scales towards maybe we should do upfront combination, versus if you don't have that co-mutation and you have exon 19 deletions, which tend to respond longer to therapy, and you don't have brain mets, and everything then starts tipping the other way. So it's like a scale deciding amongst these factors.